Well, good afternoon, everybody. I'm happy that you could join me today for a webinar on special education for school nurses, from assessments to IEPs. And I'd like, again, to welcome you today. This, just so you know, this session is being recorded and it will be made available for future viewing by others. We really have a lot of content to get through, and we'd like to have time for a few questions at the end. So I have a few requests for all of you. And the first is that there will be a drawing. So when you heard about this session, you learned that there was going to be a drawing for from those that are attending today in person. And 24 of you will be lucky enough to get a free copy of the text by our presenters, Ms. Montemand and Mrs. Gertis. And in order to know who to draw from, I need to know who is physically here, not physically, physically here. So I would ask that you please put your name into the chat, and I will do a drawing from those that have their names in the chat. Second, if you have questions throughout the program, I would ask that you type those questions into the chat as well. We will address as many of the questions as we can at the very end of the program. And then I will follow. I have already sent you an email that has the post test or that post evaluation. And so please take time to complete that one at the end of the session today, and you'll be able to access your certificate of attendance. Now, to introduce our speakers today, I want to make sure I can see them. There they are. Yes, good. So first of all is Frances Belmonte-Mann. She's been a school nurse, school administrator and school nurse for over 25 years. She's attended and written more than 1,500 IEPs for students in all educational settings. As a school administrator, she supervised other school nurses and was instrumental in the development of the school nurse division in Chicago Public Schools, the nation's third largest school system, which now is working toward the goal of an RN in every one of 638 schools. She has published nursing articles in the Journal of School Nursing. She was former clinical instructor at the University of Illinois, Chicago, the College of Nursing School Nurse Certification Program. And Jessica Gertis' career in school nursing spans almost 30 years. After working in pediatric acute care and as a public health nurse, she served 4 elementary schools in Illinois as a school nurse, participating in weekly IEP team meetings and carrying out student health goals. She served as the state school nurse consultant in 2 states, Illinois and North Carolina, for 11 years. She is a former president of the National Association of State School Nurse Consultants. And after retiring from full-time work, she taught RNs in the Lewis University in Illinois College of Nursing and Health Professions School Nurse Certification Program during their internships. And I'm happy to be able to turn things over to our presenters today. Welcome.
Thank you very much for allowing Fran and me to present this to you today. I do want to point out in this slide, we do have a perceived conflict of interest because we are the authors of the book used to develop the webinar, and it's also listed on the references. However, other than the purchase of those books, we received no payment from the state of Maine for this presentation. Today's learning objectives, they're up on the screen here. These are things that are covered probably in the pre-test and the post-test, but we want to talk about the evolution of federal and state special education laws in relation to school health, give 2 examples of how states may differ in their application of federal special education law, help you complete a thorough health assessment of a child referred for special education, complete Maine's IEP form to document the health information that you obtained, and apply the principles and practices discussed in this webinar to your own school nursing practice. At this point, to enable us to, occasionally we will stop the video of our pictures. You can just see our name over there too. Okay, so to begin with, Many of us know that Florence Nightingale is often recognized as the founder of nursing, and rightly so. She holds a significant place in the world of history of nursing. In fact, we celebrate National School Nurse Day during the week of Florence's birthday. Yet as school nurses, we should also honor and remember Lillian Wald, who was recognized as the founder of school nursing. Little history of that. In 1902, New York City schools had instituted a strict disease prevention policy. It forced many students to go home due to infectious diseases. And that's still common practice, yes? Probably in your school, you have a list of diseases for which you would send the child home. In New York City, without adequate follow-up to these illnesses, schools were soon depleted of students. So the school district in New York City asked Lillian Wald if she could help out. Now, she was a critic of that send home policy because it did not include follow-up. And she thought that government should also take an active role in treating the students instead of just sending them home. And I believe that's probably your thinking too. So New York City schools and Ms. Wald agreed to have one of her nurses at the Henry Street Settlement, and that's a public health and social work agency in New York City that she ran, go to 4 city schools for which there had been the greatest number of exclusions for medical causes. Lena Rogers was that nurse, and she was assigned to a 1-month-only pilot project to see if she could improve school attendance by reducing the health issues that caused many children to be excluded. The pilot project did phenomenally well, and it demonstrated that a nurse's work with school children and families, quote, made it possible to reverse the previous outcome that excluded children, end quote. And it kept children in the classroom and under treatment. Well, that's our slogan, right? All of us. We want to keep the children in school and treated for any kind of diseases and chronic health conditions they may have. She also found that many of these students that she visited had special health needs, and some of them didn't go to school at all. And that's when special education, helping children and youth with special healthcare needs, came into being. Now, what is a child with a disability? Okay, the federal law defines it thus: a child who has an intellectual disability, a hearing impairment, deafness, a speech or language impairment, a visual impairment, blindness, serious emotional disturbance, orthopedic impairment, autism, traumatic brain injury, you guys know it as TBI, and other health impairment, a specific learning disability, deaf blindness, or multiple disabilities, and who by reason of those need special education related services. I read this because it's straight from the US Department of Education definition of a child with a disability. You'll see here that there are 13 disabilities that currently qualify for special education with federal funding. So after evaluation, a school team would need to find the students as fitting one of these categories. And if not, the student does not qualify for special education and related services. How many students in the US receive special education? Well, the most recent estimate we have of students from preschool age 3 to age 21, that's the oldest at which a student would be eligible for special education, is about 14% nationwide. The numbers and percentages vary by state greatly, as does state funding, from 9% in Texas to almost 20% in New York. So how do you think Maine compares? Well, first, a word of caution, this slide is for ages 6 to 21, not ages 3 to 21. But in general, Maine, you can see in the 2021, the last line here, has 19.5% of their public school students in special education, about 5 points higher than the national average. Don't assume that a high percentage means a naturally higher number of students with disabilities. You don't grow students with disabilities any more than any other state in all likelihood. As you might guess, a good or a higher special education funding and related services, such as the school nurses and all, might attract parents to move to those states or schools that have better services. For example, a district may offer more services than the minimum, such as free before after school care with a nurse because they might take care of those students with disabilities. They might offer more transportation. In other words, they qualify if there's less mileage between the house and the school than the state might require. They might have some great parent support groups, great transition programs, and sometimes parents gravitate to those states with good special ed services. So don't feel bad that Maine is in a higher percentage than the national average. It may mean that you're just doing a good job and people like to be there. Here is a list of the 13 qualifying disability categories of students receiving special education, ranked in Maine by how many in each disability have IEPs based on that disability. I've highlighted OHI, other health impairment, and SLD, specific learning disability, because one, these two areas have the highest rates, and by definition, OHI would have the highest incidence of nursing needs. The SLD, specific learning disability category, is significant to school nursing because it is the only category that federal law specifically requires vision, hearing, and health to be evaluated. SLD categories requires to eliminate several possible causes of a specific learning disability, including health, but also attendance, social worker, cultural issues, absent for family events, language barriers, etc. I would say that if I were a student in France, I'd have a learning disability if they didn't roll out the language barrier. So there is an increased number of students you'll see on the line that I've highlighted in red, students with special medical needs, OHI, over the past few years, but less in specific learning disabilities. Not a huge number difference, but it's flipped a little bit from higher specific learning disability to higher OHI. So how did we get to the current special education services? From the time I was a young student in the 50s and 60s, we had only one child with mild Downs and one blind high schooler in my entire 12, 13 years of public school education. Today, there are 14% of students nationwide in special education. To be fair, there were some key early federal legislation that supported improved programs and services for students with disabilities. Most of them related to training of teachers of the disabled. Also, there were pushes to caption movies for students, for people that were hearing impaired, and some specific grants to provide more targeted services, such as Braille books. Even with these early grants and progress, the fate of many children with disabilities, handicapped children as it was called then, was likely to be dim. Too many of these individuals lived in state institutions and were merely accommodated, many with adults, rather than assessed, educated, and rehabilitated. Think Forrest Gump's mother. She was told to institutionalize him. Or view the Crib Camp, a Disability Revolution movie on Netflix. That is a great documentary showing that early history and advocacy led to improved services for people with disabilities. So it was not until 1975 that far-reaching educational law for disabled students was passed. The far-reaching original law, EAHCA, Education for All Handicapped Children Act, is more commonly known as PL 94-142. That's what it was known as when Fran and I started in school nursing. It was known that way for more than a decade. So PL 94-142 was the landmark original ruling. It set federal mandates for these 6 principles and services. 1, the basic principle of the law to guarantee a free and appropriate public education, known as FAPE, to students with disabilities. 2, include all children with disabilities from ages 5 to 21. Later laws added it 0 to 2 and 3 to 5. It defined and described 11 disabilities within the law. Later, 2 more were added to make it 13. If a student qualified, develop an individualized education program for each child eligible for services. And I emphasize the word individualized because it means it's not just one plan. It means a plan made specific for that student. So we don't use cookie cutter plans or sample plans and just copy and paste them into a student's IEP. 5th, all children and youth with disabilities will be educated in the least restrictive environment, that's known as LRE, and receive related services in the LRE. Originally, the term mainstreaming became popular back in the 70s and 80s to describe LRE. And then finally, there's a due process procedure that assures parents a right to and a process for special appeal. Excuse me, too fast on that one. Okay, then later, 94-142 became IDEA, and that's what it's currently known as, the Individuals with Disabilities Education Act. And in 1986 and in 1990, there were major additions to the law. Most notably, preschool and infant toddler programs were added. It extended the guarantee to FAPE to children with disabilities from ages 3 to 5 years. It established an early intervention program for infants and toddlers with disabilities. That's a 0 to 2-year students. Developed an individual family service plan for those younger students. So sometimes a student may come into your district with an IFSP. That's for those that were before age 3. And it created the concept called Child Find, which means that school districts must actively look for children with disabilities. In 1997, there was a couple amendments, provided transition services for students by age 16, meaning services to support a student moving from high school to adult living. And here it extended 2 more categories for disabilities, autism and traumatic brain injuries to the current 13. The 97 law also extended the LRE to require the child to the maximum extent appropriate be educated in children without disabilities, okay? That's when the term mainstreaming became inclusion and push-in services were common than pull out. Congress tweaked IDEA in 2004. Sometimes you hear the word IDEIA. The I means improvement, but most of the time people just say IDEA, okay? In that law, the most important part for us school nurses is that for the first time, nurses were listed as a related support service. Previously, it only meant school health services, which means a nurse was not needed. So that did not happen without a lot of advocacy and individual contacts with our congressional representatives across the country. NASN and state affiliates, including Maine, took the lead in assuring in 2004, not that long ago, that school nurses were included in the IDEA. And then finally in 2015, ESSA, that Every Student Succeeds Act, was passed. Every state has an ESSA plan. And so I could encourage you to look up your ESSA plan if you have not already done so. And then finally, I want to say that each state adopts its own rules to carry out IDEA. So not only the law, but also the rules that get implemented are things you need to know about. That's why there's so many variations among the states as to some parts of the law. If you came from another state, you might say like, oh, we required transition services at age 14. Well, it could be that your state made the law more inclusive at a younger age. There's a variety of things. Each state cannot go less than federal, but they can go more than federal as far as the services that it provides. So now we're going to switch slides and speakers to Fran.
Hello, everyone. Our main goal is to help children. We're going to discuss about the 2 different concepts, the MTSS and the RTI. RTI means response to intervention. Interventions are those educative modification teachers use with children in the classroom that may need help. The RTI still is used in most states, but it may be rephrased to the MTSS, which is the multi-tier system of support. Sometimes the concepts are interchanged, but here's the differences. More than RTI, the MTS is a whole school approach, improving education for all students. Tier 1 is a foundation for all students, just similar to our public health model. The tier is for prevention, designed to be very proactive for academic achievement, reduce behavior issues, and increase social emotional education. The primary tier is for education prevention, universal screening, proactive curriculum, qualified instructors and staff. It represents all students across the school setting at all times. Tier 2 targets support from some students in a small group in the school, a group of maybe 5 to 10% of the students. It is a secondary prevention. Supports provided in addition to instruction and to a student in a more universal setting. Tier 3 is more intense support. So if a child is not being successful in tier 1, tier 2, we move on to tier 3, as you may be aware. Sometimes with tier 3, if a child may have a health impairment, it may cause some academic struggles. We'll discuss 504 later in the webinar. Tier 3 is reserved for individual students for whom tier 1 and 2 support is insufficient. They're not making progress in their work. These interventions are intense and assess frequently for measuring student reports, so changes can be made when necessary or a student is not responding. Although often referred to as Tier 3 is not special education, a student may receive Tier 3 support that is making gains in achievement and is setting as long as the child is making some progress. If the MTI or the RTI is not helping a child, it's considered with the parents and the teachers, and at the school, they may consider initiating a case study to investigate. Who's on the IEP team? Federal law says the team must include the parents. Parents to me are equal partners in the IEP meeting. For the Maine regulations, parents are considered equal partners with school personnel in making these decisions about their child. And the IEP team must consider the parents' concern and information they provide regarding their child and determining if a child needs an IEP, developing one, reviewing one, and revisiting one if the child is not being successful in school. The requirements to have a representative of the local education agency means someone who has the authority to assign staff and budget to the service, such as your school principal, your administrator, head of special education department, a key counselor. The IEP team should also include, but often does include, any related service personnel that may be providing services for the child. It would be a school nurse, a social worker, a speech and language profession, physical or occupational therapist. Other staff members who know their child very well should be included in the meeting. The child with the learning concerns, if they're invited, I believe adolescents should be invited, and also younger children who would like to know what's going on with their future. Also, you may have a language interpreters. I strongly believe if you have a language and the parents need help, I think it's not good to have someone from the school, a friend interpreting. It should be a school staff, if not an outside agency should help with parents, because it's very confidential about their child. Child parent, family advocacy, community members, a clergy, tribal elder, who may provide information about a culture appropriateness of the plan. I think that's important. There's so many different cultures. We have to understand that at the IEP meeting. Key members of the child, grandparents who are taking care of the children, step-parents, any older siblings who provide daily care for the child. Anyone the parent would like to be invited to, I truly believe they should be. Well, the school nurse is definitely by each state as to who qualifies for the title. In Maine, the rule is an RN with a bachelor's degree. There are certain exceptions, such as when a school can hire a nurse who's making progress towards completing her degree within 3 years. In IDEA, the definition and qualification of an IET member is left to the state. IDEA qualified personnel means a person who meets the specific state approval or the qualified qualification. These qualifications extend to personnel hires as contractor, such as agency nurse may be contracted to the school to help to do an IDEA. The health evaluations in some states are only done by a qualified RN, a school nurse, but in others, it may be done by a physician. In other states, a combination of personnel, such as a nurse, MD, or a social worker. In most states, an LPN, a health aide, or a school secretary is not qualified to do a health evaluation on a child. In working to do a health evaluation for special education for a child, remember the nursing process that we've learned many years ago in nursing school. The nursing process is the framework for a nurse to do decision-making that allows critical thinking and creative problem solving. Using the process is the best way to provide evidence-based practice to the child to benefit from special education services. The IEP actually mirrors the nursing process. Keep in mind the assessment, the planning, the intervention, and the evaluation. Those initial discussions are called different things in different states. Sometimes when we have the meeting with the parents, it may be called a domain meeting, teacher assistant team meeting, individual student meeting, the PPS meeting, or the TAT. It's based on what your school policy is referred to. Some administrators or teachers would do these meetings without the nurse. But if the nurse is not present or providing input, the school may miss critical health information that only a nurse knows, or may stop at a known health issue without looking at the past. Nurses, go in depth, prenatal, the birth weight, neonatal, that may impact a student's learning. If the school staff recommends further evaluation going into the case study, we do strongly recommend that the nurse advocates for evaluating all sections of health, vision, and hearing to develop a baseline for understanding the child's health. In some states, a full evaluation is required for all initial case studies as recommended. If the presents are present and after the domain meeting, the school nurse will discuss with the parents known health issues concerning the child's health, vision, and hearing to determine if any of these areas of concern are impacting the child's learning. The nurse later studies all this information, and she will write her report and consider an impact, what health issue is impacting the child's health. Main requirements for evaluation for special education is evaluation is trained and knowledgeable personnel, as we mentioned before. The areas to be evaluated are done if appropriate, but how can you say that if it's not appropriate, if you don't check into the whole health? From experience doing this for a long time, sometimes you look at the current physical at the 5th grade and everything is normal. But then when you talk to the parents, you have a different idea within the past. For our webinar right now, we're only concentrating on children grades K to 12, but nurses may also do an IEP evaluation assessment from children 3 to 5 from early intervention programs. School nurses will perform or review screening. We observe the child to determine classroom's behavior that may be impacting the child's learning. The school nurse will also interview the child when possible for their own perception of their health and learning. Interviewing the parents or legal guardian for detailed health history, past and current issues. Ask about early intervention. Did the child receive that? If so, do you have a report? Ask any key questions about developmental milestones. Make sure you use your tools for evaluation, which measures are valid and reliable. School nurses review all the medical files, health records, attendance, discipline, follow school policy, sign in your name to check out the child's academic records, following your school policy. If you review the records, you need to write down your signature, because a parent needs to say, why are you going into my child's records? You legally have to tell the parent that. The nurse determines the depth and breadth of the health evaluation, which tools you should do. Nurses need to rule out any past or present medical issues that is impacting the child's learning. You're the key expert on this. This is your domain, basically. Keep in mind the timetables. The IDA sets minimum number of days for your report to be completed and the IEP needed to be held. But a school district can reduce that time if they feel it's urgent for the child. Instead of 60 school days, they may say, we'd like this report done in 30 days for the evaluation to be completed. The items listed here before it is part of the evaluation, especially under specific learning disability. But all students undergoing a special education evaluation or initial case study needs health, hearing, and vision. What does Maine need in their report? The key thing is, I think, the referral question. What is the parent's concern? What is the teacher's concern? And why is this child not being successful? Who initiated the case evaluation referral? Was it from the teacher, the parent, or was it from the result of the Tier 3 RTI when there was no progress made after a few months? Observation, when and where would you observe this child? I would definitely put it in your report. Clinical observation, what did you see? Neurological screening, I think that's very important. A hearing screening, vision tools. What tools did you use? What did you use? Because you maybe question what current screening tools did you use, and it's important to have that available. Summary of the evaluation procedures, such as the procedure used for hearing screening, like rescreening referral, should be written there. The evaluation of your health is your nursing critical theory observation, your impressions, your nursing diagnosis, and Manda in any language. What do you think a nurse needs to do for this child, and which of those specific to a child's educational needs? I always think it's very important. If you provide a service for a child, because a child is receiving special education, your service will improve the child's learning. That would be a key question I would internally ask myself. I think one thing as nurses, when we come to a meeting, I think it's fair that we should always keep our biases to ourselves concerning before you hear all the reports, evaluation, and parents' concern. I think if a parent doesn't agree with you or the team members, they can bring their own reports to the meeting or write their own statement of disagreement. Some parents bring their healthcare provider, their therapist, and provide a report. I think this is very important. Just follow your school policy on that. I think it's very important the different behaviors that may affect a child's learning at any age. The attention, the time on task, personal preparation. Observe the child play and behavior. Review developmental areas. Note attention span. I think eye contact is very important for a child. Observe fine large motor skills. Observe speech patterns. Listen to their articulation. See if a child may have a hearing concern at this time too, and observe how the child is behaving compared to his other children in the classroom. If the child is able, interview the child for their own views of their health and learning. Reflect on the classroom behavior as best you can. Your school nurse consultant, Emily Pullen, has developed a video that is excellent. It's on the vision and hearing screening. Please review this video as soon as you can, and the link is in this slide. Hearing screening. Ask the parents for the result of the newborn hearing screening. Collect your hearing results to determine on the child's medical health folder or the schoolhouse software. I need to tell you, they used to, in the past, when I did this, sometimes in your software, only we give you the current information, and I wanted to see a pattern. So sometimes you have to look at the past school records for a pattern or go dig up the written reports from the hearing text. But you need to see that. Have they failed constantly? And is there any follow-up? Current hearing screening to me is very important. It should be within 6 months of the evaluation. If the child has failed many hearings, you need to talk to the parents to follow up with the school audiologist, the child's primary care, or your BD specialist. Review the same thing with the vision. Does a child wear glasses in school? Does a child, are they prescribed? Does he have a good pair? My feeling is sometimes the children have lost their glasses, they're broken. I would strongly recommend, if possible, if there's a clinic that helps your school, ask if they could provide another pair of glasses. So the second set would be the classroom teacher. So if the child forgets it at home or breaks it, you have another set, because it's very important the child cannot see. And you see that when they are squinting at the board, just observe them. Any history of any medical problems, cataract surgery, it should be reported in the thing. 6 months, as I said before, if you do get a corrected vision report back from the doctor and the acuity is 27, strongly recommend that child has to go out for a functional vision screening through your school system. So now you did all your evaluations, you've written it out. You are going to go to the EDC meeting. This is the Education to Determine Conference. There's two parts. Once you need, the first part is you have to determine, read all your reports if the child is qualified for special education. Second, the second part is that you have to, if the child is qualified, you have to write an IEP. A school nurse or any professional doing these need to understand some basic concepts and acronym. If you're new, you have to understand the city. There's taken us years to figure this out. But as a courtesy, I always like to review these terms with the parents, especially a parent whose child is undergoing initial case study. If possible, try to sit next to the parents. Nurses, to me, are the most respected professions. After 9/11, the firemen. But I know from experience, they always would say, "Where's Mrs. Belmonte Mann?" And they would be sitting right next to you. So I think that's a strong bond between the parent. Keep in mind the concept, as we mentioned before, the FERB, the LRE, evidence practice, and review them and to be able to defend your concepts at the meeting. And also too, it's very important to understand your State Nurses Practice Act, your dedication issue for your state. And keep in mind environmental and direct care. That would be part of your recommendations of any.
Okay, so now we're going to look at the categories while you're at that eligibility determination conference. Which of these 13 categories might fit the child? You might count here and see that the last one listed is developmental delay, and it makes it number 14. So what's wrong with this picture? Well, there are 13 federally qualified for all children. The 14th is developmental delay, DDUs for short. It can be a category used for children ages 3 to 5, preschoolers, by federal law ages 3 to 9, or a subset of the ages of 3 to 9. In Maine, they've decided to use 3 to 5 for 5-year-old kindergartens to be allowed to have the category of developmental delay. Doctors sometimes use the terms developmental delay and developmental disability to mean the same thing. They're not the same though. Kids can outgrow their developmental delays, such as speech or physical development, but developmental disabilities are usually lifelong. DD is often used for a child disability category that the teen can't quite define. They want to see if they might outgrow their symptoms, like an early, ADHD type of symptom might be one they might call developmental delay, especially if the parents, don't agree with the ADHD as a category, as their child's issue. And other kinds of things. Sometimes the quirkiness of the child will cause people to say, there's something not quite right. We can't put our finger on it. We'll use developmental delay. Often it's kind of unspoken, but a lot of these kids eventually end up being diagnosed with autism. And you can certainly understand why developmental delay is a much more palatable term to use for many parents than autism. In Maine, I mentioned that it's used for ages 3 to 5, not 3 to 9. In Maine, a 5-year-old who has transitioned from early childhood special education, meaning the 3 to 5, to a public school, and has been determined eligible under developmental delay by that earlier grade level. The state of Maine says that if the IEP team cannot achieve consensus on a different criteria for the kindergarten year, the school district may continue the eligible child under DD for that year. During the kindergarten year, however, the IEP team will determine by means of further evaluation whether the child is eligible as a child with one of the 13 disabilities. I want to mention a little bit more about specific learning disability. It's defined in federal law as a disorder in one or more of the basic physiological processes involved in understanding or in using language, spoken or written, which the disorder may manifest itself in the imperfect ability to listen, think, speak, read, write, spell, or do math. The disorders included conditions such as perceptual disabilities, brain injury, minimal brain dysfunction, dyslexia, developmental aphasia. In order to avoid having every child who is struggling academically from being labeled as having a learning disability, they must exclude some items and criteria out of the students' issues. So in other words, you can't say a child has a specific learning disability if it's primarily a visual or hearing or motor disability or a health issue, or intellectual disability, let's say just a low IQ, an emotional disturbance, cultural factors, environmental disadvantage, economic disadvantage, or a limited English proficiency. That's why for these students, it's very important for everybody in the team to do their own observation of this student. And sometimes you notice something that they might not notice. You might also be called in to do some kind of data collection, such as a time on task. Those are often done for students for which ADHD may be an issue. In any case, record what behavior you see in comparison to those other ones in the classroom. Sometimes you might find that the student that you're observing seems to be doing just fine compared to this other kid that you're like, I wonder why I'm not looking at that kid. That kid seems to be out of the norm. If the exclusionary criteria are deemed not relevant, there still may be some other issues that don't qualify for SLD. Like you have an unmotivated student, that's not really a specific learning disability. But even if the student has said, oh, he's fine, he's just unmotivated, you as the nurse might want to look into something such as mental health issue, depression, or other kinds of issues. In either case, a child who is categorized as a specific learning disability, each group member must certify in writing whether the report reflects their conclusions. If it does not, and team members include parents, remember, if it does not reflect their conclusions, then that member must submit a separate statement presenting their own conclusions. Also very important for us nurses is other health impairment. It's defined in federal law as having limited strength, vitality, or alertness, including a heightened alertness to environmental stimuli that results in limited alertness with respect to the educational environment. Okay, so these are some of the things other health impairments are listed. In federal law, it says such as, and these are listed as such as, all right? What I want to say is that if you know of a child that has a health impairment, it's not one of these, and you still want to say that other health impairment is impacting the child's education, then make sure that they're aware of it. It does say such as, it's not limited to what's up here. For example, just last week, July 26th, the federal OSERS, which is the Office of Special Education and Rehabilitation Services at the U.S. Department of Education, issued guidance that clarifies that for young children and students, long COVID can be a disability that gives rise to an IDEA plan, and may also be a disability under Section 504 if they're doing okay academically but are still struggling because of those long COVID symptoms. Consider a Section 504 plan. A child, of course, may have a health impairment that does not qualify. Let's say an allergy to foods that can be avoided, or an allergy to insects. They have an epinephrine pen with them, injection pen with them. They have a 504. If they have a health impairment that is not specifically impacting their education, then they would not qualify for that category to be used for their IEP. Okay, so when you go to the eligibility determination conference, there's a few things you want to make sure you do. First, sign in on the meeting, put your name, and also your title, your nursing title, your RN. It's just, you know, you'd be surprised that many parents don't realize that the school nurse is really a nurse. So make sure you put the title over there. I had a child one time say, what does the RN mean? Real nurse? I said, yeah, exactly. Okay, you're going to separate your findings and data collection into, make sure you have objective data, which is the stuff you glean from reports and all that, school attendance records, academic records, disciplinary issues, immunizations, etc. But also the subjective data. What does the parent think? What does the student think? What does the teacher think? And what do you think? These are all subjective. Be brief but complete. You don't need to go from the beginning. The child was born at 9 months gestation with a perfectly normal, you can skip that. Prenatal history was normal, no significant issues. But then if there are, the child was apoxic for a few minutes while the cord was wrapped around his neck. Those things are important. I know a nurse that one time said people in the room could not figure out why this child wasn't learning. And finally, she just had to burst out, folks, she had the cord wrapped around her neck for 10 minutes, and so this, oh, okay, that's significant. So that's where you need to list what you think about it. Remember, parental consent is required. Do not start the specific evaluation until you're sure that the consent is received. Many times the school nurses get from their administration a form that says that the parents have consented. Now our due dates are this and that. Okay, we're going to take a moment here to switch speakers. Fran?
Yes. There are four main components that you should be aware of if the child is eligible for the IEP meeting. The first is the functional performance, develop an annual general goal. And the third is the short-term objectives. That to me means small steps to address the annual goal, to address the functional performance, what is impacting the child's learning. The fourth component is a progress component that's very important. We have to see if progress, the school has to see if progress is being made by the students. Now, at this time, I strongly recommend would you take out the form from your state concerning the IEP. And we're going to review that briefly. Reviewing the form, if you would look at section 3, the considerations, towards the very end, it says, does the child have a functional developmental needs? This is something, if you feel the child does, I would mark yes at that. The next page. Is number 5 section, the measurable annual goals. Before that, you have to write a number 4. If you said there was an issue, you need to write down your findings of all initial evaluation and your evaluation of the student in one of the little boxes under section 4. And under that, you have the progress monitoring the annual IEPs. This is something that would be in after an annual, you would write down with the codes if the child is making progress. That is under the progress monitoring annual IEP goals. Number 5 section, you would have to measure the annual goals under your law. And that would be under the second page on page 3, the functional developmental performance. This is what you would write. If under this section, you would see the little section we're going to discuss the present levels of performance, a measurable goal, objectives, and progress. On the last page 4, on page 4, related services, is middle of the page, it says nursing services. This is where you would write the position, not your name, but you would write the school nurse or the administrator who may be helping at that time. The location, it would be the classroom, where in the nurse's office or in different area. Frequency refers to the time and place where this intervention that you're going to provide. The duration beginning at the end is a calendar year. And the next page, page 5, if the student was older, as we mentioned in 16, you would do post-secondary transition plan, section F, and you would fill in appropriate daily living skills or functional evaluation for a child who's in transition. Thank you. The Maine Association of the School Psychologists has published guidelines in establishing specific learning disabilities. There's a special section. In this section of the 4, this is where the team, including you, will mark down a vision or hearing concern, a yes or no, then explain in the plot or in related services the action. A plot in different states have a different title, but it basically means the same. It could be the PLAAFP from 204, the plot PLOP, or the PLP. Maine's uses function performance. Functional performance means how the student demonstrates his or her skill, behavior in connection, communication, motor, adaptive, social, emotional, and sensory areas. The PLOP stands for the present level of academic achievement and how the function and performance of that student. Some districts refer to the plot, some just say PLP, and some just say PLB. The plot to me is a starting point or the baseline for the coming school year. The most important thing was the impact state. Would the child benefit from special education instructions if he's eligible for the IEP with the support of a school nurse? Is a nurse or paraprofessional needed and a one-to-one for daily care and safety and in medication? Just think if the child can benefit by your nursing interventions to improve his special education instruction, this would warranty for you as a nurse. There are different types of services that you can provide. Direct services, hands-on teaching, help counseling to the student, indirect, obtaining orders for a medical provider, overseeing other house staff, consultation, educating the staff about the child, continued conversation with the parents. In our case study for the rest of the webinar, we're going to use Judy. The first paragraph is what we call the plot, the PLAAFP, and her name is Judy, as I mentioned. We're using this for the rest. The second paragraph is the impact statement. This is where the medical condition is impacting the child's learning. For this example, the team has agreed for SLD as a primary disability, OHI is a secondary disability, and she qualifies for IEP. Now we're doing the part 2 of the IEP meeting. First, we know she qualifies, and this is just a diagram how the nurse has to describe in her IEP how the child functions in school, performance of her ADH, including her school, personal health performance. Is a child in the nurse's office daily? How much time? That's very important. If a child's in your office 1 hour a day times 5 per week, that's 5 hours times 4 is 20 hours. When you think about it, that's almost 4 school days the child is missing classroom instruction. Also, you need to describe the child's strength, the area of her unique needs. Discuss with the IEP team and the parent, of course, whether your nurse's services will be provided, your time, your place, the schedule, frequency. It's very important to minimize the time out of the class. Discuss what nursing service will be provided in the class or out of the class. Discuss the child's IEP health goals related to the health issue. These goals have to be student-centered, not a nursing goal, but student-centered, and discuss this with the parents. Discuss the child's medication treatment, any supplies that you may need with the child. Infectious control to me is very important right now. The child has cystic fibrosis and COVID. Yeah, that's a big issue, I think, in coming in the next year. And even the Delta will be a big issue coming in here. Safety factors, evaluation plans, ambulatory, wheelchair, lockdown, oxygen, other equipment, modified physical education activities, homebound, if the child is sick, needs homebound, hospital teaching is needed, bus drivers, aides, ramp, private bathrooms, and an elevator if this child will benefit from being in the school. Nurses have nursing goals, as we know, but for the student, the child is student-centered. So I would consider using the acronym SMART, specific goals, target to the child's function and performance, measurable, needs to be able to be objective, scoring the goals and objectives. Action words to me are important. Increase, decrease, maintain for a baseline. Realistic needs of the child and achievable. Time limited. Parents and child need to know and monitor child's progress at stated interview, annual meetings, report cards, and interview. Child's annual IEP goals should have short-term objectives. I always consider them small steps to address the annual goal. The object should reflect the child's uniqueness and ability to achieve his IEP health goals. I strongly recommend, these are the resources based on the IDEA, the 204. They want evidence-based practice. As you can tell, there's a list. But I always think it's important if you find a very rare disease, you can look this up at the NORD website. And I would ask the parents' permission if you would share it with the staff and the teachers, so they're aware of a very rare disease that this child has, or any of the major health problem. When you're writing the IEP health goal for the child, first you have to understand the plot and the impact statement, how the child functions. Second, when you write the IEP goal, is a general statement to improve her asthma. That's why she could be attending class more. There may be more than one health goal in a child, but most of the time I think 1 to 2 for a student is appropriate. Nursing goals may be accepted to be written into the IEP team, but even if not, nurses should incorporate his or her student's health goal if she's written a health goal and objective. Write positive actions in the annual goal. Child will state, child will recognize, child will check, child will take. Nonverbal children, I would consider writing an IEP health goal. How does a child communicate with their eyes, head movements, facial movements, sounds they make, and other response to stimuli? For our student Judy, the goal is to improve her knowledge about her asthma triggers, her response to those triggers, thus her attendance in school, so she will be more successful. Learning standards are very important because they refer to how the child may be learning, and it's in the educational field, but the learning standards are important. This is something you could write in your plot. I'm going to show you Maine's education health standards by grade. Okay, maybe the next slide. Yeah, that shows up over here. Yeah. All right. Okay, we just talked about that. Well, can we go to this? The learning standards are very important. After learning the standard that you think is appropriate for the child, I would decide what standard to write into the goals. The one that I'm showing now, this is grades 3 to 5, the health learning standards for Judy's IEP. Transition goals, as we mentioned before, is for a child that would be 16 and over. If Judy was 16, we would write a transitional goal, and the law requires that it's important. Every state is different. You may have a state that's saying you need to discuss transitional goals for age 12. Some states say 14 or 12, 14 or 15. But our student is 10. We won't have to write this, but this is something you should be aware of. If she was 16, it's important to learn how Judy needs to fill out a script, make appointments, be very independent in her own care. Parents and the students should be at the meeting that includes the transitional services. Now, after we write the annual goal, we have to write 3 short-term objectives. And these are just a few. Judy identified what factors or triggers are creating an asthma episode. Judy would demonstrate the proper asthma inhaler techniques. Judy would keep a log of her absentees or of leaving school early and discussing with the nurse whether these absences were necessary, and if so. It's all based on the unique needs of the child and what she is able to do. She may know all her triggers, but she doesn't know how to use her asthma inhaler properly. This is the form that we showed before. This is the form that Maine would like you to use. The top little square box, this is where your present level functional development performance. And also, as we mentioned, I would put in the learning standards at this time. The measured goal it would be by the date, the given the service, student's name, skill is her skill that you would like her to know, measured by the evidence. Objective requirement, I would say yes if you develop a goal, also given by date, service student's name, and the skill you would like her to know. And the progress, this is a narrative. Like I mentioned, you need to fill this out after the annual review next meeting. Section 7 is what we talked about in the reform. As we mentioned, do not put your name in it because it could change. It could be a sub who's doing the work, but your nursing credentials to me are very important. I would put my RN license there at that time, or the LPN. This is where we mentioned before in the box. By the end of the IEP, given the nursing services, Judy would provide her knowledge about her asthma triggers, her response to those triggers, her attendance in school, and to be successful in the school environment. The objectives require, and I would put a yes, by the end of the first quarter, Judy, given the nursing services, will be able to name at least 2 asthma triggers as measured by successful listing 2 triggers with accuracy. This is another objectives, and we went through. By the end of the school year, she would demonstrate proper asthma inhaler techniques. This is a third objective if you use this. By the end of the school year, Judy will keep an accurate log of absentees or early dismissals and discuss with you, the nurse, whether and why these absentees were necessary. On your form, you need to write the progress. Follow your school policy or the Department of Education measurements criteria. That's very important. You have to make sure the child is making progress. Follow your policy. Evaluation criteria could be numbers, could be percents, or the use attempt, 3 out of 5, or other methods, notes for conferences with the nurse. Evaluation procedure is a written material. It's something you could see, a log, a chart, test, or any progress notes by the nurse. Schedule for determining progress, such as a daily, that would be a child that you have to see daily, a weekly, a quarterly, any mild to moderate, I would see a child, at least based on the needs, I would see the child, or other, whatever the child may need. The dates reviews could be the report card distribution, parent, teacher, and conference. We know we pick up the phone or you email the parents all the time, but for documentation, you have to follow your school policy. Progress must be measured from a baseline. How many triggers does she know, and how many currently does she identify her symptoms? I would always start with low, so it's achievable percent, or increased number of attempts as measured. I would say she knows 3 out of 5 triggers, 4 out of 5 triggers. By a whole year, within a year, she should know all her triggers and respond back to you. The narrative description of progress is what we talked. If she's not making progress, you need to alert your school staff and the parents to review this. Measurable achievement and the short objectives, as I mentioned, is short steps. And this is over time. Keep in mind, it takes a little while to do this. You may not see this within a first month. Child's progress or lack is very important to observe and show with the IEP team. Progress would be measured at the end and likely 1 or more points during the 12-month period from the beginning date of the IEP.
Thank you, Fran. I'll pick up here with this slide. So for all these services you're going to be providing to the student, is this district going to get paid for that? Hopefully, yes. Most of the time, a child that has an IEP also has Medicaid, or in your state is called Maine Care, because there is a clause or a waiver written in Medicaid plans that allows Medicaid reimbursement for these students, even if their parents make enough money to not be on Medicaid normally. Okay, so you might wonder, how come we're billing Medicaid for this student? They have a nice house, nice cars, whatever. It's because of the waiver. The U.S. Department of Education and the U.S. Department of Central Management Services, Medicare and Medicaid Services, have agreed to reimburse school districts because they don't get enough funding for special education. So You're going to be, in most cases, being able to provide to your district a number of minutes that you'll be doing for each of those services, and then total up the number of minutes that you'll be providing monthly, quarterly, annually. You'll be able to be billing the Medicaid, and you'll have your own billing number. Each state has a little bit different plan, Medicaid plan, and that's something that Emily can go over with you sometime. Emily, as you may or may not know, is the National Association of State School Nurse Consultants representative to a program called Maine, National Association of Medicaid in Education. So she is quite qualified to answer your questions about Maine Care and how it's written. But in general, your nursing minutes are determined by the medically and educationally required direct care or teaching provided. Okay, what by that we mean direct care is a hands-on to the student, with the student's face in front of you. There may be some services you provide, like coordination of care, speaking to parents, updating plans and all that. Those are indirect. And although they're written in the IEP, they are generally not reimbursable. Now, some states have also been amending their plans to allow some of that to also be reimbursable. So it varies from state to state as which services are reimbursable or not. I encourage you to look at the website for Maine Care, the guidance on Maine Care reimbursable services on the individualized education program. They updated it in just this past May 2021, and several related services are identified as reimbursable, including the nursing services. You must document this on the IEP, which means that the state of Maine, Maine Care, may go in and look and say, well, wait a minute, you're billing us for hearing screening, but there's nothing that says the doctor says the kid needs to be hearing screened more frequently than is routine for everybody. So we're not covering it. So it has to be services that are required medically. So if the child does have a hearing impairment and the doctor has written, please do a hearing screening on the child quarterly so that we can determine if the child is maintaining or has reduced hearing, if the loss is progressive or not. So that's very important to know that there is medical documentation that the service is needed, and documentation also that you provided the service. So most of the time, your state Medicaid agency is going to try to match up. Is there a documented medical need for this? And were they provided, with the minutes being reasonable is how they determined that. So here's a sample idea, a little schedule for how you might determine how many minutes you normally need. You can either do what's called a minutes documentation, how many minutes you actually spent with it. Most of the time rounded up to 15, increments of 15 minutes. But let's say a child is in generally stable health, but needs some of your nursing services, such as Judy. She's stable, in reasonably good health. She needs a monthly visit of 20 minutes, 5 minutes per week, to talk about her asthma management, to teach her and have her demonstrate what she's doing. She needs also some acute asthma episodes, may come to you in between those other visits. So let's say an additional 5 minutes weekly or 20 per month may be written. So this means basically 10 minutes a week, and you're rounding it up to 15. Now you have other students that are more involved. Let's say a recently diabetic student that comes to you all the time to try to check her sugar, to try to get the glucose monitoring equipment updated, to check the tubings, whatever. And so you may have 60 and 120 minutes per week. Or the really complex child with a ventilator, whatever, may have more minutes required. But again, there are some sample plans in your Maine Care, and you can see what might be reasonable minutes to apply for. So as I mentioned, you need to document two things. The one, that the child has those medically required services to be provided, and the documentation of the services being provided. There's a couple of other things that I want to point out to you about documentation. If you're speaking with the parents outside of an IEP meeting about their IEP, document the conversation. It's always good to have that, because the parent might say, I told her that her asthma was getting worse. And then you would say, like, well, she said, I'll check back with you for her asthma. That's what was written in my notes over here, and we didn't hear back. And here's a note saying that I called her and left a voicemail asking about her asthma. So it sort of protects you. You can say, I always document conversations with parents, and that's your legal backup. Okay, you need to make sure again that your Medicaid matches, alrighty, and your programs and documentation can be audited by the Maine Department of Education or your state Medicaid department. Even outside of Medicaid, make sure that your activities are always well documented and that you could defend the care that you gave. If there were a legal challenge to you because of the nursing care you did or didn't provide, make sure you can defend it. If it was delegated to somebody, make sure that you're aware that that person was demonstrating appropriate care, that you supervised occasionally and all that. Documentation really is paramount. We all learned if you didn't write it, you didn't do it. A few things about some other meetings that might be required. Now, federal IDEA requires that each of these plans be reviewed annually. Now, it doesn't mean that the whole thing has to be done from the beginning, but review them annually. It's basically your annual report card. See how the child is doing. You might update things, particularly if you have a school health goal, about how she was doing on that. Update things that the teacher might not know, like glasses were obtained in the meantime, or glasses were lost or broken and you're working on getting them repaired or replaced. Look at the charts, look at the office visits, see if there's any trends. Is the child absent at the same period every day or in your office at the same period every day? What about injuries? Sometimes a student that's bullied on the playground comes to you and is wanting to get away from the playground. Then there's the required 3-year reevaluation. And that's required by IDEA, basically to see if the child still qualifies and to write a new IEP. So the child may have grown out of the IEP, so to speak, may doing so well that you got, we love it when we see a child that outgrows the IEP, that gets so, because the services provided were so good that they don't need an IEP anymore. It's kind of like if you've ever worked in a nursing home, aren't you happy when a person actually gets discharged, So it means that everything is better and you've done well. Most students, unfortunately, though, in our experience, will keep that IEP through 12th grade because those issues sometimes are just not, they're doing better, but they're not totally resolved and they still have issues. Some other meetings that you might be called upon to attend. There's something called a BIP, Behavior Intervention Plan. Make sure that you know about a BIP plan. If the child comes to you from the playground and you determine the kid was the instigator, make sure that you realize that that child has a behavior plan and follow that. Okay, there have been issues with parents say like they had a BIP and yet they were, put in timeout. They're not supposed to be for that particular behavior. It's related to also the manifestation. There is the acting out or other behaviors of a diagnosis that manifests in that disability. For example, Tourette's with tics. Sometimes those students speak, 4-letter words out loud. That's part of their behavior. If there's a rule that the child will be sent out of the classroom, disciplined or whatever, playground privileges removed, that needs to be in the plan, and a manifestation meeting if sometimes creates that BIP. There also may be a student that's new to your school district. If they come in with an IEP from another district or state, federal law requires a concept called stay put, which means they will remain with that IEP until the district says, yes, good enough, we'll implement that IEP, continue with that IEP, or we're like, we're not real sure about this. We'd like to do another evaluation or something. And let's say you have a child come in from a state where developmental delay is okay up to age 9, but not for Maine. You'll have to go back and have another IEP for that student to find a disability category. Briefly about 504. This webinar is not meant to talk about 504, but I do want to bring it up over here because some students have a 504 and not an IEP. Quite often the 504 comes first because you know about the disability, the parents know about the disability, and then later during the course of that student's education, they find like maybe this disability, this health issue, whatever, is really impacting the learning, and then they might go into an IEP starting with their tiers 1, 2, and 3s and some other measures. Now, some people, if the child does not qualify for an IEP, they consider a 504 being the backup plan. It's not a consolation prize. It doesn't necessarily mean that they will get a 504 plan. It is something that you discuss. And if possible, I suggest that you take a class or read a book on 504. Remember, the school nurse is accountable for all of this. All these things here, the Section 504 laws, make yourself familiar with that. Individual health care plans. Each student with a health problem that you might encounter in the school should have an IHCP. And some national leaders speak out in this and say, not that they should, but that they must. Okay, because your licensure depends on it. If other parents, other teachers don't know that this child has a health issue, then they might ignore something that should be reported to the nurse. Okay, emergency care plans. I know that you're busy. You can't write an individual health care plan on every student that has a health issue. So triage them, the ones that have emergency issues, the students that are diabetic, the students that have severe allergies, the students that have seizures. Those you want to make sure that you get an EAP out the door just as soon as possible and follow up with an IHP. Please know about FERPA. If you're new to school nursing, this is probably new to you, but it's the confidentiality law that nurses in other settings know as HIPAA. It's totally different. It does require confidentiality, but from there it separates whether the school district and whether you can share health information with the social worker within the school. Yes, you can. Whether you can share that with somebody outside the district, no, you can't. Know some other issues like DNAR or PULSed. Everybody knows what DNR is. DNAR means do not attempt resuscitation. And that's a clarification that, you may start resuscitation and it doesn't work. That's, DNR, but don't even try it means DNAR. And there's in some states something called PULSed, physician orders for life-sustaining treatment. And that's where it's a little bit more written out, sort of like the living wills and all that, where it says, if this, then that. So just to summarize, we have a couple of points over here we'd like to make sure that you're aware of. We do believe the nurse has a special role. We would not be doing this if we did not believe that. We also believe that using the nursing process is your best guarantee for doing the best you can in your assessments, your plans, your interventions, and your evaluations. Make sure you keep up with state and federal education and health laws. They change frequently. Make sure you keep up with whatever Emily Poland has been sending out to you about new laws or best practices. And if you have any questions, contact your district nursing manager and or then your state school nurse consultant or State Department of Nursing practice. In general, we suggest that you go through the chain of command. So bring up your issue or your question with your district nurse leader there. If you're in a small independent district where there's nobody else to consult with, then you might just check out with somebody in the next county or with the health department or something else. And then finally, the state school nurse consultant. I was a state school nurse consultant in 2 states, as Emily said, and quite often when they would call me, I would say like, well, have you discussed this with your, next in chain of command with your district nurse or whatever, and encourage them to say, well, discuss it with them. And then if there's still some issues, bring it back to me. And I might say, in the meantime, here's some resources you could look at while you're discussing it with your supervisors. Okay, a couple of quick things about references and resources. We have several here listed. I want to point out the crib camp that I mentioned earlier. It is really something that I encourage you to see. It will give you new insight into the issues of disabilities, particularly way back in the 60s and 70s when there was almost nothing for people with disabilities. Look at your guidance for Maine Care. Look at this guidance that we put together about who should, must, probably will be at your IEP team meetings. Fran mentioned something about the School Psychologists Association having a guidance there. Read that. Of course, make sure you bookmark your Maine Department of Education and National Centers for Education Statistics if you need to find something more for your presentations or your research. And of course, Fran and I would like to plug our book there. It's listed there with a link to it. And then the U.S. Department of Education. And then one final note from the 2 of us here. We both want to, again, we wouldn't be doing this if we didn't care. We are both retired from active school nursing. We have other things that we might want to do, but we very much care for the next generation of school nurses behind us. We want to leave a legacy. At our age, we want to know, what did we do for the next generation? Did we pay it forward? And by doing things like this, we want to demonstrate that we care and we know that you care. Now, if we can turn this back to Emily, she will discuss some questions that came up in the chat box. And for the time possible, for maybe about another 5 minutes or so, we'll answer some questions.
Thank you so much, Fran and Jessica. I'm trying to unpin your video so I can maybe see some others, but there actually are not any questions in the chat box, which is so interesting to me that there aren't any, but there was so much information that you provided. And one message that I got as a private question, and I won't call out who sent me a message, but was how often are nurses really disinvolved in an IEP meeting? I think that from the way you described it, like the nurse is right there for every single IEP. Has that been your experience where nurses are involved in every single IEP the school might have?
Right, want to take it first?
From my knowledge, to me, for doing this for so many years, it was required. They said, yes, you have to. That was my ongoing when I first started. I had a nursing director and a district, and it was required. The school nurse had to attend all IEP initial case study meetings.
And I will echo what she says. I worked in 2 different school districts, and in each of them, the nurse attended each IEP meeting, including those annual reviews as well too,
Yes.
for the full length of it, and did a full evaluation, including the health from the beginning. I know there were times I was sitting in those IEP meetings going, oh gosh, they're talking about a specific learning disability. It doesn't really involve me. I got so much else I could be doing. Later on, I was able to be a little bit more proactive and say, I've completed the health history, the health evaluation, vision and hearing screenings. My report is ready to give. If possible, can I be the first one to present? And then if there's no other issues that come up that need my attendance, could I be excused? And that often is how nurses can sort of streamline their attendance and be able to do everything else that they need to do. But there are sometimes the parents want you there, and you should discuss that in advance, because sometimes the administrators will say, okay, well, Nurse Curtis needs to do on some diabetic checks, so she's going to leave the meeting now. And then you can say, like, I'm sorry, but the parent has asked me to stay and I would like to stay. And I've already been able to accommodate that student with somebody else for their diabetic check. The parents really can take the lead. And I know that some parents have been told by other people on the team, don't ask the nurse to stay, she's very busy. Sometimes I think that really comes up because they know that the nurse will present issues that maybe the rest of the team doesn't really want to have brought up. So that's where we're just advocate. We're the advocate for the parents and for the students. I know in Illinois, when I was a state school nurse consultant, when I was promoting this concept that was not in every school district. We have 800 some school districts. I was only working at 2, and that was our process there. And sometimes they would say, like, you're making more work for us. I said, yeah, I'm kind of demanding that way. So as much as possible, I get it. You're very, very busy. So again, triage the students, at least for every case study, initial case study. One of my supervisors at the State Board of Education said, he says for every initial case study, he recommended that the nurse do a complete health eval, because in his words, this is the first time that health and education were looked at together. All right. Teachers looked at one part, nurses looked at another. This is the first time that was looked at together. So at least for every initial that comes up, please do your evaluation, give your report, say I'm available by pager or phone call if you need me to come back in.
Thank you so much. That was really helpful. We do have to recognize that things are not always the same in every school district, right?
Yes. Yes.
Well, since there are no other questions, I thank you both for joining me today in this really informative webinar, and I'm so grateful that you were able to do this for us. And like I said, I will be drawing 24 names out of our chat of who was in attendance today to send a copy of your book to them for free. And I hope that you all have a good couple of weeks rest before school gets up in full swing in a few weeks.
We have our contact information here, and sometimes people don't want to put their question into a chat box because, like, am I the only one that's asking this? So feel free to contact either or both of us with your additional questions if they come up in your practice.
Thank you so much. All right, have a great afternoon.
Thank you. Thank you, everybody.